This lecture recording, we are going to cover Chapter 11, which is complications of pregnancy. The first complication I'm going to talk about is an ectopic pregnancy. So this is one where the fertilized egg implants outside the uterine cavity. It may occur in the fallopian tube, which is up to 99% of them, on the ovary, on the cervix, or on the outside of the fallopian tube, on the abdominal wall, or on the bowel. Patients who present with vaginal bleeding and a missed period or abdominal tenderness or pain should always be evaluated for ectopic pregnancy. Pain increases after rupture of the ectopic pregnancy, and they may experience a referred shoulder pain from diaphragmatic irritation caused by blood in the peritoneal cavity. And you can see it is the second leading cause of maternal mortality and a leading cause of maternal mortality in the first trimester or the first 12 weeks. Some risk factors to be aware of for ectopic pregnancy. As I said, 99% of those implant in the fallopian tube. History of STIs or pelvic inflammatory disease. Prior history of ectopic pregnancy. A previous tubal, pelvic or abdominal surgery, history of endometriosis, current use of exogenous hormones like estrogen or progesterone, in vitro fertilization or other method of assisted reproduction, and in utero diphthylestrol, I didn't pronounce that right, exposure, DES exposure with abnormalities. And if there's issues in the reproductive organs, if they've been using an IUD or an intrauterine device, sometimes this can increase the risk of ectopic pregnancy. Okay, so some signs and symptoms of an ectopic pregnancy. Pelvic and abdominal pain is pretty classic. The pain can be unilateral, bilateral, or diffuse. They may have a palpable mass on a bimanual exam where they're doing the pelvic and they're also palpating by the umbilicus as well. That's a bimanual exam. In about 50% of the women that present, active bleeding is associated with rupture. Okay. Hypotension also associated with rupture. Tachycardia, vertigo, and then the referred shoulder pain that I mentioned. Pregnancy test will need to establish that she is in fact pregnant. Ultrasound to see where the fetus has or the egg has implanted. IV site, definitely going to need to have an IV site. May even need to be giving her some IV fluids if she's having a lot of bleeding. Oxygen could potentially be necessary. Labs like a blood type and RH. And keeping her NPO in case we need to perform a surgical procedure. Some of the medical management that we may need to perform, methotrexate can be given. It's a chemotherapeutic drug and folic acid inhibitor that stops the cell production and destroys remaining trophoblastic tissue. So it's basically contributing to the abortion. Used in the management of unruptured, uncomplicated, non-life-threatening ectopic pregnancies. Okay. Surgical removal, so a salpingectomy or actually removing the fallopian tube by laparoscopy or by doing the lasers. RhoGAM administration that's why we're checking the RH levels, because if baby's blood mixes with, even at the time that it's fertilized, you know, it's still having that. So if it mixes with mom, it could cause a potential RH reaction. And then mom will develop antibodies, which is not a good thing. We don't want that to happen. Just going to touch on very briefly RH incompatibility and giving RhoGAM. Make sure that you check out the RH PowerPoint that is on the module. So if you have an RH negative mother and an RH positive father, the mom could form antibodies against an RH positive fetus. So that's where the incompatibility comes in. So think of a hemolytic blood transfusion reaction. So mom's antibodies will actually cause a destruction of the blood cells. of the baby. Okay, so we will give her what we call ROGAM to try to prevent that, to try to prevent her from developing those antibodies, because there's a very slim chance that there could be some transfer during delivery. So that's why we want to check her Rh factor so early in the pregnancy, because she will get ROGAM at about 27 weeks of her pregnancy during the second trimester, and then, or through the third trimester, I'm sorry, and then she'll get it again 72 hours after she delivers. Hyperemesis gravidarum, or excessive vomiting during pregnancy, it could produce weight loss, which is not good. Dehydration, she could get acidosis because of the starvation, because she's just not able to eat. She vomits everything. Alkalosis related to loss of hydrochloric acid in the vomiting, and hypokalemia. Remember, you lose more than just fluids when you're vomiting. So we must recognize the signs and symptoms that are associated with each of those problems. And it could be related to the increasing of the human choreo hormone or estrogen levels. It could be related to any of those. Sometimes these women require hospitalization if it's bad enough, if they're starting to lose weight and they're really getting dehydrated and starting to show symptoms of an electrolyte imbalance. They may require hospitalization to receive TPN briefly to try to restore some of those nutrients and electrolytes until this time passes. Normally, after she gets through the first trimester, this type of issue is going to resolve. But definitely, if she starts losing weight and she's showing symptoms of electrolyte imbalance, that's an issue, and she definitely will need care for that. Pregnancy-induced hypertension. So chronic hypertension, if she has a history of chronic hypertension. Another name for it, gestational hypertension, because it occurs during pregnancy. Preeclampsia. This is a form of pregnancy-induced hypertension. It's not exactly the same. It does have other symptoms involved with it, and it's a much more serious condition that we need to be aware of. Preeclampsia is superimposed upon chronic hypertension. So obviously if mom has a history of chronic hypertension, then preeclampsia becomes more of a risk. And then eclampsia, where she has actual seizures. That's how we know she's eclamptic, when she's having seizures. As far as the cause of preeclampsia, they don't really have a definite cause of preeclampsia, but pregnancy-induced hypertension, preeclampsia normally don't surface or show signs until about 20 weeks of the pregnancy. Gestational diabetes, this is diabetes that occurs during pregnancy. This mom may or may not have a risk for gestational diabetes. If she has family members in her family that are diabetics, obviously she's going to have a little bit more of a risk. But it could happen with someone that has no risk factors for diabetes. The one thing to note and to make sure that we're educating the woman about is this could end up being permanent. Usually once the baby is born, this problem will resolve, but in some rare cases, it could end up being a permanent problem. Increased morbidity and mortality. We want to screen and diagnose early, obviously. We want to keep her sugars within normal limits throughout the pregnancy to decrease the potential for complications to both mom and baby. We need to recognize the signs and symptoms and the consequences for both mom and baby because of increased sugar levels. Babies could end up being large or macrosomic. That's what we call large babies, macrosomic. They could also have an increased risk of preterm delivery, which is not good for baby. Betamethasone or dexamethasone, those are steroids, so those could actually increase sugars just like they would in your diabetics that you've already seen. So we have to be careful when we are administering that, because cases that you may need to administer those kind of steroids, those are what we call antenatal steroids. If there's a risk of preterm delivery, we will give those to help to develop the baby's lung tissue. It's going to help the baby's lungs develop. So that will decrease the risk of respiratory problems after baby's born. Okay, so an incompetent cervix or cervical insufficiency, so painless dilation and effacement of the cervix. Patient usually reports histories of multiple second trimester losses. This occurs more commonly in the second trimester. It could be acquired or it could be congenital. Okay, it could be either of those. Management is a cervical cerclage, which is an actual suture that they put in the cervix to try to keep it closed. They actually have to remove that at the time when the woman is getting ready to go through labor. Preterm labor that occurs between 20 and 37 weeks. Some signs and symptoms: regular persistent uterine contractions and any cervical changes. There are some risk factors. Obviously, if the woman has had a preterm labor in the past, she's going to be at an increased risk of preterm labor this time. If she's gestational diabetic, that could increase her risk of preterm labor as well. So some medical management of preterm labor: if they can't stop the labor, if there's no way to stop it, tocolytics are given to temporarily delay delivery because we want to be able to give those antenatal steroids that I mentioned. And this can be given in patients between 23 and 34 weeks. So teberdoline is one. Utapar is another one. Those are beta-mimetics. Indomethacin, nifedipine, which is a calcium channel blocker, and magnesium sulfate. So magnesium sulfate is given, it's off-market use for preterm labor, but mainly used to preserve the baby's brain function. It's not really a tocolytic in the traditional sense, but it does help with the baby's brain function because preterm babies have very delicate tissues in the brain. They have very delicate arteries, and any kind of stress could cause those arteries to rupture, causing a bleed in the brain. Tocolytics allow time to administer the antenatal steroids like betamethasone. It's contraindicated in patients with infection, with hemorrhage, or if the delivery is imminent. The ideal dose is 2 doses. They can give 1 every day. They need to have at least 48 hours in order for this to really have any effect. And it's given to try to help the baby's lung tissue, the lungs develop. Premature rupture of membranes. So the membranes will rupture around the onset, usually right before labor begins. That's one of the indicators that labor is going to begin. So they will rupture before the onset of labor. They obviously, they rupture too soon. They rupture before they should because the body is not ready to go into labor yet, but now, we kind of have to jump the gun a little bit because now there's an increased risk of infection. There is also premature or preterm premature rupture of membranes, which happens before 37 weeks. Obviously, increased risk of infection because once the membranes rupture, there's an open conduit then to the uterus from there. Some signs that the woman has an infection: obviously, if she's having a temperature above 100.4, if she's having any foul-smelling vaginal discharge, if she has any elevation to her white count, if she's having uterine tenderness, maternal and or fetal tachycardia. Those are all clues that could lead to that mom potentially does have an infection. And if mom has an infection, that could affect baby. Baby could also have an infection. Placenta previa. So this is where the placenta has implanted in the wrong place. We expect the placenta to implant at the top of the uterus, right up at the top. But with a placenta previa, it implants down by the cervical os, or the opening where the baby is going to come out. So with this placenta previa, they have painless, bright red vaginal bleeding. Stabilization and fetal monitoring, there's really not much that has to be done for this. They just keep an eye on it, basically. No vag exams, though. They don't want anything going in there that could potentially cause bleeding. Abruptio placenta, so that is an actual separation of the placenta from the uterine wall. Sometimes the bleeding, it's dark red bleeding. It's very different from the previa. It's dark red instead of bright red. They will have pain from the separation. A partial separation, it may not be a lot of pain, but they're going to have concealed bleeding. There will be bleeding, but you won't be able to tell because it's only partially separated. Okay. Um, Most commonly occurs in the third trimester. Could occur for many different reasons. Could occur because the blood pressure gets too high if the mom is preeclamptic. It could occur if she is in some sort of an accident and has blunt force trauma to the abdomen. That can cause a separation. A complete separation, that's a problem because now the placenta is no longer attached, and ischemia is definitely going to be a risk. Plus, there's a lot of bleeding that could happen. And again, may not see it, so it could be concealed. But the pain and the symptoms that mom is going to be showing, possible drops in her blood pressure, those are all indicators. Her abdomen can become really rigid, just like with any kind of rupture, it could become very rigid. So it's definitely something to be aware of and to know the signs and symptoms of, because this kind of situation, you could end up losing mom and baby. Depending on the extent of the abruption, they're going to do an ultrasound to see the extent of the abruption. They may not have to have a cesarean section. It really depends. If this is a complete separation, then they need to get that baby out as soon as possible. But if it's only a partial separation, they may be able to let the pregnancy progress normally. It really, or the labor, I mean, but it just really depends. If mom's not in labor at all, then they may need to. It really depends on how mom's doing. Okay, so that's all I've got for this recording. If you have any questions, let me know.